But without further ado, I want to bring up our speaker, Dr. Koh, if you want to start coming up here. Dr. Koh is a longtime friend of the LGS Foundation and a pediatric epileptologist and doctor to many of our families here. She's going to kick us off as we talk today about LGS-associated disorders. Specifically, she's going to be talking about the seizures, but also the non-seizure aspects. And then right after her, Dr. Gupta is going to come up and she's going to talk about sleep issues in LGS as we kick off the day and start talking about LGS-associated disorders. And here you go. If you just push that forward, there you go. Dr. Koh, it's all you, and you can take your mask off while you speak. Great.
Wow, good morning. It's truly wonderful to be here in person. The lights are blinding. It's, I think, 3 years ago when I was here last time, and I had a wonderful, wonderful time. And I'm going to tell you a little bit about what it means to have support system and to counter these very abnormal brain activity. And in a way, the physiologic activity we do, something we do, we take it for granted, the daily conversation we have, having friends around, and not being alone, how important that could be for Lennox-Gastaut Syndrome. So it was my good friend Ann Berg. I think she has enlisted some of you. This was a very complete survey in an attempt to understand the natural history. So it was part of the natural history project, where 37 parents from USA, Australia, and Netherlands participated. And there were about 43% girls, 57% boys, aged went from 0 to 16 plus. And you see about half of them were actually older than 16 years of age. The etiology, still big portion, over 60% were unknown, but what we see is brain malformation and genetic disorder, I think, taking a big part now, as we know how to diagnose, in a way, the single nucleotide changes that could actually make a difference. So now we are learning how to detect, I call it, one misspelling in a book, and that could actually cause conditions such as Lennox-Gastaut syndrome. So acquired injury has gotten much smaller portion at this point, about 5%, but the genetic condition, chromosomal disorder plus the single nucleotide changes can cause Lennox-Gastaut syndrome. It was remarkable to know that 97% of the survey participants reported seizures in the past 6 months, and 75% had seizures every day in the past week. And 58 had triggers, including hyperthermia and excitement, and sometimes just a bright light. And overwhelming majority had prolonged seizure that was greater than 10 minutes of any type, and many of them were convulsive, could be non-convulsive, myoclonic, and others. And 51% had used rescue medication or sometimes would use bridging medication to prevent at the time of illness. And 30% have gone to ED or were hospitalized for seizures at least once, of course. I think that's not uncommon. So sleep, it turns out that the parents don't sleep at all. 81% parents monitor their child's sleep. 75% seizures greater than over 33 nights in a week. 39 reported that child wake up 3 nights a week with or without seizures. And 39% reported restlessness or greater than 3 nights a week. So how do you know that, right? Because you're up and monitoring them. And of course, vast majority of you reported moderate to severe fatigue. It just reminded me of what it's like to be when baby is born in first 100 days, and you have the babies with you all your life, almost all their lives, when they have poor sleep. And yes, it's been like a roller coaster for you. The sleep is so important. We are designating one session. Dr. Gupta will be following my talk to talk about sleep exclusively. So I don't have to tell you that Lennox-Gastaut syndrome is not just seizures. It's the combination of the seizures and the aftermath of seizures, the rescue medicine you give, the effect of that rescue medicine. I've been told that sometimes a day is lost once the diazepam is given. And this all lead to cognitive, behavioral, and psychiatric disorders. And we don't have really ideal medication yet. And I can tell you, many people are still working very hard to find that ideal drug that has less side effects. And we've come a long way, I have to say. I think there's reason to be hopeful. So these are the survey results about functional ability. So 58% require a wheelchair and mobility device. 46% have significant visual impairment. 25% typically do not use hands to manipulate objects. 50% do not speak words. 42% depend on the caregiver for feeding. And 54% inconsistently or rarely communicate, even with those people they know. But I do think that most of our patients and children will let you know what they like and dislike. And I think that's a blessing. 32% dress themselves, and 38% can use spoon, 4% can brush their teeth, and 30% wash their hands. 29% can drink from a cup. And these are all very relevant information, I think. 46% uses some kind of electronic device, iPad, their favorite object to take with them. And they could use crayons and have, about 1/3 have simple academic skills. And 42% can independently ambulate and walk. About 17% can use the toilets. So when Enberg did this phenomenal study following patients for 25 years from the very first time they presented with new onset seizure, when she went over and looked at all the children, there were about 519 children that she followed, she found about 1/4, this red line, where they never really achieved seizure freedom beyond 1 year. And you would all agree that Lennox-Gastaut syndrome families belong to that about 20-25% of this what we call long-term refractory epilepsy. And what I like to point out is some of them have broken line, and then after many years of uncontrolled seizures would become seizure-free. And some of them represent, I think, some of the successful surgical cases. It's been known that when there is a childhood onset epilepsy, intellectual disability is an essential comorbidity. So anywhere between 20-30% of children, when they have childhood onset epilepsy, will have intellectual disability. This trend is actually really important when there is an early onset epilepsy. So when the seizures occur before age 2, they all tend to cluster in this below 70% IQ point. So the earlier the seizure onset, the harder it is for them to be able to have a normal intelligence. And the degree of the severity of intellectual disability seems to also go with how young they were when they started to have seizures. And as we all are aware, the early onset epilepsy, especially younger than 2, sometimes are due to genetic condition. They are born, their DNA has been altered, and that's lead to the epilepsy. What we have known for many years is in general, not just Lennox-Gastaut syndrome, but in general, children with epilepsy, their IQ is shifted to the left. And not only that, we have watched many of these children going downwards, even if they started with normal intelligence of 100, if they have poorly controlled epilepsy, it could go down to 70, 65 in 10 years. And we have watched them helplessly as they deteriorate over time. And this is sometimes what I use to advocate for early intervention in terms of surgical cases. When you know there is an actual lesion, you do not want to watch them deteriorate over time because neurons are not born again, except for a very limited area in the brain. So seizures and cognitive outcome tends to go together, I think. So we have profound intellectual disability and moderate to severe intellectual disability. Some of them have typical to borderline IQ, and that size of the pie seems to be very closely related to the seizure freedom they achieve as they get older. So you see the vast majority of people with LGS continue to experience seizures as they get older. And this was a graphic representation of amongst those 519 patients that Anne Burke followed. She looked at specifically on 22 people with LGS, and what she found was their seizures were quite frequent. It could be per day even. You see this dark line representing greater than 30 seizures a day, and half of them had moderate to severe most of them had moderate to severe ID, intellectual disability. So it's not just seizures, but they're very frequent, happening multiple times a day. So looking at the 38 patients with Lennox-Gastaut syndrome in adulthood, a similar finding. Some majority will have monthly to weekly and still daily seizures, even in adulthood, and their mild, moderate, severe intellectual disability are noted. So how come all these, even when they start out with normal intelligence, why is there this decline over time? And the way I see it is the seizures are just the tip of the iceberg. When you look at the EEG of Lennox-Gastaut syndrome, by definition, this is what you see in between seizures. This slow spike and wave discharges, disruptive activity in the brain that's ongoing all the time. And sometimes when they fall asleep, we see this beta buzz. This is paroxysmal fast activity, burst of polyspikes. Essentially, the brain is bombarded with this very abnormal brain activity, even when they are not having seizures. And this is an absolute prototypical example of epileptic encephalopathy, where it's defined as the epileptic activity itself that may contribute to severe cognitive and behavioral impairment above and beyond that what might be expected from the underlying pathology alone. So when the brains are bombarded with this pathologic, very active abnormal brain activity, brain changes, and especially during critical period of development, it interferes with normal wiring of the brain. So the point of critical period has been well known, and Hubel and Wiesel have done experiment where they blind one eye for temporarily during this critical time, and then the brain cannot see through that eye. So you are aware of that condition called amblyopia, when there's a misalignment of the eye that itself can cause vision impairment. And another example of the critical period is the songbirds. The baby birds learn to sing with the father birds. So when fathers sing, boop, boop, the baby will say boop, boop, and they learn. And if you don't learn to sing, what happens? They cannot find a mate. So it's a very critical, and this happens in this very critical period of time. And if I were to think of epileptic cacophony and think of your brain being bombarded all the time with this abnormal activity, what happens is that you cannot really sing, you cannot write the music. There is a hardwiring of the singing or music making, and is not able to make the sense out of it. So, do we give up, or what can we do? This is probably the best example, a best study that has been shown, not in Lennox-Gastaut Syndrome, but in Dravet syndrome, where it's a same single gene mutation, sodium channel 1 alpha 1 subunit has been altered. And before we understood about what's indicated, what's not indicated for Dravet syndrome, many of the children were having multiple daily seizures on a sodium channel blocker, which is contraindicated. And what we see is if they were on this contraindicated medication for longer than 11 months, their IQ shifted. So yes, if you will be the advocate and say, if you see yourself, what is supposed to be really good medicine for LGS, but on my child, this particular medicine does not work. It's making seizures worse, and it happens. I always tell my students, anticonvulsant has potential to be pro-convulsant. So you see it yourself, and you can identify what does not work for your child and avoid contraindicated medication. Avoid medication that will worsen seizures. You are the best eyes, and you can help physicians to have an action, do some important action of stopping that medication. I mentioned this before. Those children who become seizure-free, those rare conditions, it is even in just looking at the LGS, there were certain children who benefited, who were candidate for surgery. And when we did that, there was actual reversal of IQ. I think it's significant when someone with IQ of 35 has 20 IQ point improvement after surgery. That means that he's able to use hands, able to go to the bathroom himself. I think these are functional changes that occur with 20 IQ points increase. So consider it. And I think here I am hopeful too. We used to think of LGS, unless there is a defined lesion, they are not surgical candidate. But now we have not just resective surgery, which I think when we look back 100 years from now, considered to be barbaric, taking part of the brain out. Now we are in this era of neuromodulation, the responsive neurostimulation. I think these are the things that we need to consider for LGS community. And I want to share with you the story I shared with many of my patients. what I learned doing basic science research in the laboratory, what our little critters have told me. And this was an experiment of enriched versus isolated environment. Some of the animals housed 8 together versus isolated all by itself. And what we saw was at the end of even just 10 days, you see how some of the animals have a trading wheels. They are very active, but not only the exercise they did, but they had each other and tumbling and playing together and having this kind of enriched environment made a big difference after seizure. So what we found was huge impact of enriched environment versus isolated environment, where if the animals were isolated after first seizure, they were more susceptible to have second seizure very quickly. There was lowered threshold after first seizure, but if they were raised in environmental enrichment, that was normalized, as if they haven't seen the first seizure. And this improved seizure threshold was correlated with inflammation-related genes that were highly upregulated in isolated animals that were reversed by enriched environment. And visually, what you can see is this incredible microglia activation, those immune cells in the brain. In isolated canid animals, they were completely normalized in enriched environment. And this was one of the most anti-inflammatory intervention I could make, was having them in an enriched environment with each other, playing and having interaction, the social interaction they need. I think one time I shared this information with Adam Todd's family, and now Adam is taller than me. This was when he was not as tall as me. He became a runner. And we all know exercise, the running, walking, increases neurogenesis, and is truly enriched environment. And I think I like to say that support of the community, not being isolated, having that enriched environment will make a huge difference in anybody's life. And we learned that through the COVID isolation, I think. It's not healthy to be isolated. So the goal of therapy, because you don't want to be on 7 anti-seizure medication, is elimination of most disabling seizure type and reduce the side effects. What good does it do if you're seizure-free, if you're sleeping all day? I put it in quote, minimal polypharmacy or therapy. And from my own experience, I do not give up until I have tried these 4 combinations. And that's known to be synergistic with each other. Valproic acid and lamotrigine together, clobazam and Epidiolex or CBD together. Those 4 have been a magic bullet combination for me and for my patient with Lennox-Gastaut Syndrome. Number 4, safe and enriched environment. Striving for best possible quality of life. And of course, we should be thinking about treatment of comorbidities, such as sleep disturbances. We also be mindful of the weight, alertness, and the tremor that sometimes caused by medication we give. Safety issues, avoiding falls, aspiration pneumonia. It has become the best friend of not elderly, but children with LGS. Burns, status epilepticus, seizure clusters. Now we have Nasolam and Valtoco. I think those are a wonderful new way to provide rescue medication. And of course, we think about SUDEP all the time. Sudden unexpected death in epilepsy, especially with nocturnal seizures, especially with uncontrolled convulsive seizures. We worry Postictal state can be prolonged. Sometimes it could cause postictal psychosis. It's okay to use risperidone in those cases. So to summarize, I'd like to tell you that LGS is prototype of epileptic encephalopathy, where seizure activity and interictal abnormal brain activity itself can cause changes in the brain and intellectual disability. The frequent seizures and interictal epileptic discharges contribute, I do believe, in intellectual disability, and it is the common accompaniment of all early life onset epilepsies, including Lennox-Gastaut Syndrome. What we do know is that 50% of individuals with IQ below 50 have epilepsy. And be mindful of quality of life and treat disabling seizures as soon as possible. Consider surgery, neuromodulation, and ongoing screening and monitoring for not just intellectual disability, but mood disorder from initial visit and throughout the care. Avoid medication that exacerbates seizures or cognition, but try and try again until you find the right combination medicine, and it's become much more possible now. Yes, I think right combination makes a big difference. Consider surgery, ketogenic diet, and other non-pharmacological treatment. I consider PT, OT, speech, these as part of the enriched environment, having that interaction with the caregivers. And yes, I do think there is a reason to be hopeful, so never, ever give up. Thank you very much for your attention.
Dr. Koh, we have time for questions if you'd like to. Sure. Great. Any questions? Please raise your hand and we'll get you a mic.
Hi, Dr. Hello.
Hey,
hi, Dr. Koh. Thank you for your talk. I always love hearing you speak. I had a question. You mentioned the combinations you always try. You mentioned Epidiolex and Onfi together. Within our community, a lot of families say their interactions with those two drugs together urge against this combo. Can you just talk a little bit about why you think this combo should be together and why it's one of the things we should try?
So when Epidiolex in a clinical trial and when Epidiolex became available for Lennox-Gastaut Syndrome, many patients were already on maximum or supramaximal dose of clobazam. And we do know that when CBD is added to clobazam, the clobazam, the metabolites, breakdown of that metabolites is profoundly affected. So not just the CBD, but mostly the I'm blinking, that metabolites, the active component goes up 10-fold, 20-fold. So many families have seen and went through, and because they stay in the body for a long time, it's very difficult to get rid of them, right? It takes a month for it to come down. So what you saw immediately as the CBD was added was this incredible sedation, and that's because we did not expect it and we kind of came unprepared. So yes, sedation becomes a huge deal. But there was a point where the community even wondered, maybe the part of the CBD efficacy is because of clobazam, because we increased the level of clobazam. So they did a meta-analysis, and they looked at all the papers, all the studies that were done, and what they found was CBD alone, without clobazam, was efficacious, but their effective size was not as good as when the clobazam was on board. So we're convinced, I am convinced, that clobazam and Epidiolex can work together as long as you don't increase the metabolite to the highest level and cause sedation. So the clever way, so same thing with lamotrigine and valproic acid. Whenever I actually prescribe lamotrigine on top of valproic acid, I get a phone call from pharmacists. Like, this is contraindicated, it causes this trouble, that trouble, but they are synergistic. I am convinced that lamotrigine and valproic acid and clobazam and Epidiolex are synergistic in their action. We just have to be careful and be aware of that particular effect of CBD blocking the catabolism of the clobazam metabolite. So I think it's wise to decrease clobazam, but not stop clobazam. I think we are losing the opportunity to make a difference. So through the meta-analysis, what we have learned is that, yes, having CBD on board makes, having clobazam on board makes CBD better than CBD alone.
Awesome, thank you.
Other questions?
My question is actually related to that, to the magic combination. So you would perhaps you would try to have my child is not on any of these except the Epidiolex, and I'm actually not even familiar with the first three. Wow. So how we've tried Epidiolex, I'm not convinced it's actually helping. She's on 3 other seizure meds that are not any of these. What would you say to something like that? You would put a child on all 4 of these at the same time? Is that what you're saying?
No.
Or how does that work? What does that look like?
For longest time, valproic acid was a go-to medication. So when we look at the clinical trial for Epidiolex for Lennox-Gastaut Syndrome, what we saw was many of them, about over a quarter, over 25% were on valproic acid and clobazam already. And of course, we also worry about, right, with Epidiolex, with CBD addition, we also worry about liver function tests going up. So there are a lot of caution, a lot of reason to be cautious. What I also want to tell you is that there were some wonderful studies. It was our experience that valproic acid and lamotrigine work very well together. But specifically for Lennox-Gastaut syndrome community, there were studies done with many numbers. I think it was presented last time when we were here, of institutionalized children. And when they did all sorts of analysis, only 2 medications fell out of that whole analysis. Was this valproic acid, lamotrigine, are the ones that made a difference. And another study that we are very familiar with is the childhood absence epilepsy study, where valproic acid, lamotrigine, ethosuximide were 3 drugs that were tried, and it was this lamotrigine valproic acid combination that led to best synergistic action. So I think people who have used valproic acid as a go-to medicine for a very long time, and this was before all this new 2nd generation, 3rd generation medication came about, we are very familiar with valproic acid, lamotrigine working very well together. And then came clobazam, and then came Epidiolex. So I don't give up until I've tried all those 4. But it's over time. It probably takes, especially when you're adding lamotrigine to valproic acid, it takes, 4 months for it to reach certain safety level, the therapeutic level, because we worry about Stevens-Johnson syndrome, the drug rash, that's scary. So we will take 25 milligram lamotrigine in half and give for 2 weeks just 12.5 milligram to make sure a child doesn't develop rash. So it's a long process, but I think it's worthwhile.
Great. Other questions? I can't really see, so just start talking if you have a microphone.
Tracy, I have a question. I'm curious, you have a slide that mentions the IQ point raising 20 points after surgery, and so that we're all not rushing out for an immediate surgery. Can you tell us a little bit more about what surgery in particular, and is it because you are seeing a decrease in seizures that you're seeing an increase in IQ?
That's a very good question. So these were the children who had multifocal brain lesions and were not considered surgical candidate, and they developed Lennox-Gastaut Syndrome. These are children who had infantile spasm, many of them, because of the diffuse brain injury. So these are structural epilepsy cases. And people have given up on surgery. But then this medical center looked at those children and found a focal area. So not all Lennox-Gastaut syndrome will have generalized seizures. They can have focal seizures. And they screened and found the surgical candidates. When they are surgical candidate, they went ahead and, so there are only a few numbers, right? But when they are structural epilepsies, where there is a focus can be identified that causes seizures, even if the interictal abnormality seems generalized. When there's a focal lesion, and they can be surgical candidate, and I think that made a huge difference. Yes, they have become nearly seizure-free, and that also led to, I think, increase in IQ, but also, I think, in addition, the interictal abnormality also has decreased significantly. So I think it's a combination of both seizure freedom and removing that site that incites that abnormal activity. So what I am hopeful for is, yes, even the RNS requires certain focality to the abnormality of the interictal abnormalities and interictal discharges, but I think RNS has potential in even diffuse structural changes in the brain. So I think it's something to think about, and especially earlier in life, before everything gets hardwired. I think early intervention goes far. So I think it's something to think about. It's not everybody's surgical candidate, but if you become surgical candidate, then I think it would be a great idea. So we have used VNS, that is neuromodulation, and many patients have benefited from vagus nerve stimulation. So that's where I'm going. So not just medication, but a surgical intervention, and that choices is becoming wider, not just VNS.
Great. I think we have one more question right here.
Hi, I love coming to this conference to hear these golden nuggets about the synergistic effects of these medications. That's amazing. It's so wonderful to know. I think many of us are actually doing our own N of 1 clinical trial with various combinations of medications. And I just want to urge all the clinical researchers who are here to really think about when they go to the research roundtable, or I'm sorry, the meeting of the minds in the fall, to really think about ways you can tap into the collective knowledge here and our experiences with different combinations of medications. I hope we can learn about more of those combinations that really do work for our kids and in which certain combinations work. And then my second question is, what we find with our child is he has a wonderful honeymoon period every time we start a new medication, or sometimes if we even increase the medication, but eventually the efficacy sort of diminishes and he's back to having tons and tons of seizures. And I wonder, where has there been research on things like drug holidays? Where is that kind of work? I know that's being used in other disorders. Will that ever be a possibility for severe epilepsy?
Oh, thank you so much for sharing that. It really is a thought-provoking. I think that whole concept of honeymoon period has been, tossed around a lot, and it's never been really thoroughly studied. I think we need a collective wisdom of why does it happen, how does this happen? Is there a way we could try again? Do we take holiday from medication? I think we need to be creative within the, not just trying but by parents, but as a community, we should do it together and gather information and learn how to do this better. Yeah, I heard about honeymoon period all the time, and we don't understand that.
Wonderful. I know that's a great suggestion, Geraldine. I know that all scientific research starts on the basis of observation, and we have to get to a point where the observations that we're all making collectively as a group and uniquely together can be brought together in a way that can help encourage scientists to know sort of what direction to go, and then also to learn from them as you treat hundreds and hundreds of patients. So let's thank Dr. Koh, and I know she'll be here. Thank you.